Thank you all. I think just for time's sake, and so we can stay on time with these sessions, these are 30-minute sessions, just so everyone knows for your own timing. Welcome all of you to our second installment of what we are calling the Orthoevidence Insights World Tour. And today we begin our tour with a colleague from Oman. Let me just also share with you what we mean by what we call the Insights World Tour. If I can get the next slide, please. Now, this group is a little bit bigger than small group, but you'll see the purpose is to have our lead speakers invite panelists, individuals that they feel can contribute to the discussion. And you will see very shortly that our keynote speaker today has invited some close colleagues and friends, and many of you, I suspect, also have an interest in this particular topic area. Next slide. So just reminding everyone, the event is recorded. We would like and request all of you during the presentation format, which should be about 10 minutes or so, we think, please remain off video and muted. We will then obviously ask you to unmute and we would have a discussion. We will move just to a panel of video, and we'll have hopefully 15 to 20 minutes of discussion thereafter. There's multiple ways. I suspect many of you are aware of these online events, so you know how to communicate. We'll look forward to any of your interactions. Remembering also that if you go to the next slide, this is one of many that we have in terms of our World Tour events. So we are hoping that when you sign up, that you will sign up for not just this one, but a number of other ones that are currently available. So do go to the website and sign up separately for each of the special events that occur throughout the rest of the next 4 days. Okay, on to our keynote. Let me go to the next slide here to introduce a colleague and friend, Professor, Surgeon and Head of Orthopaedics, Sultan Al-Maskari, who is currently the immediate past president of the Orthopaedic Society of Oman in Muscat, Oman, and has a very important and highly debated issue of damage control orthopedics, but specifically the role of retrograde nailing of femoral shaft fractures. It's a great pleasure that I invite Sultan to take the lead here and proceed with his initial slides. Sultan.
Unmute, okay?
Yes, please.
Yeah, sure. Thank you very much, Mohit, and thank you everybody for joining us for this evening. And before I start, I would like to mention that I've invited for this, as Professor Bandari said, a very important topic that is about time that we debate certain aspects of it. Some very influential people in the opinion of this topic, and I would like to mention Professor Peter Gianoudis, who's joining us from Leeds in the UK, and Professor Tilak Japagnanam, and Professor Deval Desai from India, and Professor Rodrigo Pesantes Hoyo from Colombia, and last but not least, my colleague and good friend, Dr. Narayan from Oman. And next slide, please. I'm just going to give a brief introduction about the topic so that then the colleagues in the panel whose views and opinions on the points that I'm going to raise will be greatly appreciated, and I think are important to give time to. This is a young man, 29-year-old gentleman who came with bilateral femur fractures and ankle fractures and little else injuries about 15 years ago, and along with the prevailing opinion of damage limitation or damage control orthopedics, external fixators were applied to his femurs, and he was transferred to intensive care unit. Very little else was done. He didn't need anything else. Unfortunately, less than 16 hours later, he has passed away and was dead despite all the best efforts. Next slide, please. Now, in 2005, Pape Gianoudis and others have written some influential articles. One of them is this, and trying to look for indicators for clinical decision making in damage control and or the treatment of diaphyseal fractures of the femur, and they divided patients into 4 different groups. The most common one, which requires early total control or care, is what they labeled as grade 1, but then they went up with the other 3 grades, which eventually increasing in the amount of surgical intervention and limited to only damage control by application of external fixator, and maybe even ICU for the patient who is an extremist, that is a patient who is actually literally dying. Next slide, please. A few years later on, Bone and Janudis, in a very eloquent article about femoral shaft fracture and chest injury management, they have revisited this issue this classification with a few modifications, giving allowance to the time required for monitoring to see how the patient goes on. But of course, the same concept is maintained, and that is the primary treatment for the stable patients is early total care. And the patient who is very unstable or in extremis, damage control orthopedics through whatever means, but of course is taken for granted at that stage, meaning external fixator or traction or distraction. Next slide, please. Now, in 2000, up to that point, we were practicing this, damage control orthopedics, and we still practice it, but slightly in a different way, and that's why we want to share our experience. In 2013, we were in the unfortunate position of mass casualty, where 50 patients involved in a bus crash were brought into the hospital, and all the theaters were busy. And this is a 19-year-old young lady with bilateral femur fractures and bilateral open tibial fractures, and has just had a laparotomy and vascular explorations, and she was handed to us, the orthopedic surgeons. Our external fixator sets were busy in the other rooms. She is very unstable. What can we do? So we decided to insert retrograde femoral nails in both femurs and hope for the best. And luckily, against all odds, she survived. And next slide, please. And of course, she became our index case. So since then, we have treated 11 patients, which we are sharing in this series, and we have excluded the patients that we stabilized after 6 hours. We've only looked at the patients that did not stabilize hemodynamically until a femoral shaft fracture was treated, despite those that had other sources of bleeding treated, like abdominal or thoracic, or if they didn't have any other injuries, we assumed that was because of the femur fractures. But we included in this series only the patients that we took immediately to the operating room within 6 hours from arrival to hospital. Next slide, please. So this is the list or the summary of the patients. 11 patients for 14 femurs. That means 7 unilateral and 3 patients with bilateral. The average age is 31 years and 8 were males. There you can see the injury severity score, which is quite high, the average of 28. And look at their vital signs parameters. The pulse rate, these are in the emergency room, an average of 116 beats per minute, and the systolic blood pressure, the average is 76, ranging from 55 to 90, and the diastolic is 43 average. So they're all in established shock. When you look at the hematological and the chemical parameters, they're still in compensatory mode because they're very early on in the emergency department. However, you can see that the average are acidotic or getting to become acidotic with a pH of 7.2 and lactate levels of 3.9. But the platelet counts and the hemoglobin levels are still holding very well, so they're in this compensating stage. Next slide, please. So we reviewed these 11 patients retrospectively, and we discovered some interesting results. I mean, the operating time was 29 minutes for a unilateral femur and 50 5 minutes for bilateral femurs. And the intensive care unit stay was an average of 3.5 days, but the mode was 1 day. 4 of the patients required inotropes to be started in the emergency department, but all of them had them discontinued less than 6 hours later. Next slide, please. And this is what surprised us. What we looked at is the pulse, the vital signs, the pulse and blood pressure as they entered the operating room, or if they had any other procedures done before orthopedics, before the femoral shaft treatment, from the start of the femoral nailing until their time in recovery. And we noticed that the pulse rate on average dropped from an average of 114 per minute as the patients entered the operating room to an 87 per minute in the recovery. And that's quite with strong statistical significance. Next slide, please. And the systolic blood pressure rose from an average of 83 to 106. Again, next slide, please. And the diastolic pressure again rose from an average of 50 to 67. Next slide, please. So you can see that the patients stabilized immediately. This is a typical case, and this is case number 3 in the series that's published. And this was a pregnant lady with intrauterine death of the fetus, and she had laparotomy, mesenteric tears, and of course cesarean section, but she was still very unstable. So at 0 minutes is when she was handed us to the orthopedics with a unilateral femur fracture. So you can see that her pulse rate is very high, and the systolic and diastolic pressures were very low, and gradually they changed course as with the fixation of the femur. So despite all the previous abdominal and obstetrics intervention, she didn't stabilize. Next slide, please. And this is her x-ray. So it's quite a nasty fracture, just a simple retrograde nail of the femur, smallest size possible, and locked it distally. Next slide, please. So the results in brief, 5 of the patients developed lung atelectasis, 3 desaturated, and they were investigated with CT angiograms, no pulmonary embolism or fat embolism was noticed. We didn't have any deaths, no ARDS, no pneumonia, no fat emboli, and no pulmonary emboli. In the long-term follow-up, 3 of the patients were lost to follow-up because they were not from Oman and they went back to their home countries following discharge from hospital for further care. 1 had exchange nailing for non-union, and 1 had lengthening because he was shortened. And 1 knee developed stiffness, that was the case index. No local infections. Next slide, please. So, next slide, please. Now, this whole issue has raised a lot of questions within our team and within colleagues that we discussed this. And I have to mention here some technical considerations. We're not talking about the standard femoral nailing, antegrade or retrograde nailing that you do in the very stable patients. This is a very unique, very different protocol where we use the smallest nail. We aim for a 3 millimeter difference between the diameter of the nail and the canal of the femur, or at least 2 millimeters. We only ream the entry point in the knee, which has direct anatomic access. We introduce the nail gently. We do not reduce the fracture prior to introduction of the nail because we think the fracture is an important vent to expel the medullary canal content as the nail is gently introduced. And then we use the nail as a joystick to achieve reduction. We do not do proximal locking. We only lock distally. The aim here is hemodynamic stability of the patient. The mechanical stability is relative, and we achieve the complete mechanical stability by locking the nail approximately a few days later. We use a standard radiolucent table. There's no traction, of course, direct entry point, so it's coaxial with the medullary anatomic axis of the canal. and the anatomy is simple, so it's not like antegrade nailing, and the distal lock-in is easy because you use a jig for that. Next slide, please. So this is not your standard nailing. Now, what are the differences between the classical damage control orthopedics using external fixture, and why would we go for damage control retrograde nailing? Because the external fixture will only give you partial reduction and relative stability, especially in the obese thigh. The canal contents and bleeding is patent, and bleeding continues from the fracture because it's partial reduction. There is no tamponade effect from the soft tissues, and the pin sites, the shank screws cause transfixion of the soft tissues, which may cause stiff knee later on. There is, of course, the risk of pin sites, and to convert to a femoral nailing later on, it's a major procedure. Whereas with the retrograde nailing damage control that we are proposing, you have full anatomic reduction of the fracture, relative stability. But the canal is blocked, so there is no more bleeding from the canal. And there is tamponade effect from the tissues by achieving the full reduction. And the soft tissues are free. There is no transfixion with the shank screws. And there is no pin site problems to worry about. And the second operation is minor, because it's only proximal locking screws. Next slide, please. And now, when Pape and Janudis and colleagues in that seminal article of 2005, they proposed these 4 criteria as the main reason why these patients are so unstable. And they highlighted in a very eloquent articles. Unfortunately, most of us, when we read this article at the beginning, we didn't appreciate the message in it. But now with this experience, we look backward again at that, and I appreciate the role of the shock, coagulopathy, and hypothermia. They added the soft tissue injuries, which we cannot do much about other than control their effect through the damage control. But I think if we control the shock, which has major influence on coagulopathy and patient going into DIC and hypothermia, is key to this. And I think this gentle retrograde nailing without proximal locking achieves just that. It achieves the control of further bleeding from the femur, of course, given control of other sources. And as a result, it also prevents coagulopathy and hypothermia from developing further. Next slide, please. And you can see here, I've put some examples. These are very complex situations, very complex fractures like this one, segmental fracture. Next slide, please. And this one, which is our latest patient, where the distal femur is shattered in addition to a segmental fracture of the shaft, which you cannot fix with an external fixture. In addition, the patient had open tibial fracture as well. So a nail stabilized this patient, and he survived. Next slide, please. We look back at the literature. Unfortunately, there is nothing published. All the literature that looks at comparisons of damage control using external fixtures against nails, they look at standard antegrade or retrograde, but in a standard fashion nailing. So what we are proposing is very different, and there is only one article that we came across by Higgins and Horowitz, where they had 5 patients with a similar experience back in 2007. Next slide, please. So in conclusion, we think that control of shock leads to control of prevention of coagulopathy and hypothermia, which are the biggest risk to these patients. Now, there is a lot of talk in the literature about pulmonary complications, and they're concerned about the relation to nailing of the femur. Again, there is some evidence in the literature that actually dissociates the two, and that article that I mentioned by Bone and Janudis covers this topic extremely well. Again, there is another study by Huzebier and colleagues looking at the cardiopulmonary effects and immune effects related to nailing of fractures in unstable patients, and they didn't find much evidence in that. So we still follow damage control protocols or principles. So the stable patient, early total care. The borderline or unstable patient, damage control orthopedics, but we are proposing, instead of external fixture, damage control retrograde nailing. Now, I hope I didn't take much time. Next slide, please. I would like to invite to the discussion my special guests who are in the panel, and I would like to start with Professor Peter Giannoudis on this topic, please.
That's great. Thanks, Sultan. And please, yes, please go ahead. We have about 10 minutes or so for discussion, so please do engage.
So if I may come in more, it's good to see you and everybody else. This is a great educational platform, what you have thought about. So I'm delighted to participate, and my congratulations to all the team that is trying to find all these new ideas to continue this educational platform for all of us. So well done, and thank you for the opportunity.
So what are your thoughts, Professor Giannoudis?
So very, very quickly, Sultan, first of all, I would like to congratulate you for this new approach that you are trying to educate all of us that retrograde IM nailing maybe it's another option to consider in these difficult patients as a means of damage control orthopedics. So it's a different way of, it's a different option to stabilize the femur. I think the arguments that you have suggested do make sense. It's a quick procedure in experienced hands. You minimize the second hit in terms of the timing, that you don't have to consider the proximal locking. You just insert the rod carefully, a small diameter rod without rimming, and like that you stabilize the femoral shaft fracture quickly. You minimize the risk of bleeding. You minimize the painful stimuli in the already compromised patient as a whole, the host, and you provide a similar kind of stabilization like the external fixator with a very quick procedure. So I think it makes sense. We need to gather more evidence in terms of the validity of this approach. And I think the work you have done, the first 11 patients, is very promising, is very stimulating for all of us to try what you are trying to try in our practice. What you have demonstrated, it might be another option to consider. And I'll stop here.
Thank you. Mohit, can I continue, or do you want to lead the discussion?
No, please go ahead.
Can I invite Professor Rodrigo Pesantes to give his view on this? And then I'll go to our colleagues from India.
Thank you, Sultan, for the invitation. Thank you, Mohit. Good to see you, Peter, Dabal, all of you. And yeah, I think it's a great idea. I had the chance and the privilege to talk to Tom Higgins a few years ago about this idea of retrograde nailing without locking, and it was really interesting. But again, I do agree with what Peter said, which is you may need some more tools to do that. You need an experienced surgeon. You need a C-arm to find the entry point. And at least in the part of the world that I live, it may be something that it will be used in specialized centers. But in the general hospitals, I think it's still X-Fix is the way to go.
Thank you, Rodrigo. Dr. Tilak, Professor Tilak.
Thank you, Dr. Sultan. That was a brilliant talk and your publication. My only concern is while it may work for distal shaft fractures, especially those comminuted fractures where you don't lock proximally. I was just wondering whether there was a problem with nursing with the instability. So it is an idea, but I was just wondering whether we could have done the proximal locking as well.
We wanted to shorten the procedure. We have actually, in some patients who stabilized immediately, we did proceed and lock proximally, but we didn't include them in this study. So some of the patients stabilized immediately, but we just wanted to look at the ones that remained unstable until we finished the procedure and the anesthetist. So, yep, we take that point, and we are in the process of conducting a stability study looking at blocking screws rather than locking screws proximally. So thank you very much for that point. What Professor Deval Desai?
So very interesting study. I think it makes sense that fractures return to near anatomical situations early as possible for for getting the stability. But few concerns with these concepts. One of which is, you said you're putting a very under ream nail, like a 3 millimeter smaller nail.
Yes.
So that's one side. The other side is a lot of these proximal femoral fractures have very narrow tight canals proximally. So if the time is the concern, then without reaming, would you be able to get a good, a reasonable size nail in a short time? That's one. And thirdly is, we see a lot of these patients with a pelvic or an acetabular fracture component associated. So how does that come into the equation when you use this concept? Have you sort of thought about this?
Yes, some of our patients did have acetabulum or pelvis fractures, but the main aim was to stabilize the femur. And we retrograde nail, as you know, one of the main indications for it is an ipsilateral pelvis acetabular or pelvis fractures. So that's hitting two birds with one stone, basically.
And last point, sir, would be, I think the universality of accepting retrograde nails as a treatment method is still, a lot of surgeons have resistance to using retrograde nails yet, if you take a survey. So that would also need a lot of sea of change in the thought process once you get more data.
Well, absolutely. I mean, we're not talking about retrograde nails for all femur fractures. The stable fracture, in the stable patient, we go for an antegrade nail still as part of the early total care. But this is, we're looking for hemodynamic stability. We just want to save the patient, get him through that difficult period, and then treat the fracture definitively later on. We didn't have to do any exchange nailings.
If I can add, please, that.
Come in.
Yes, Peter, please.
Yeah, very, very quickly, if I can add that every patient comes with different injuries, different hemodynamic instability, different comorbidities, if we know about them, and also different canal size and so on. So what is presented here is not a panacea for every patient. Some
Absolutely.
patients will get an X-fix. Some patients may still get a Thomas splint because they're so unstable, and we can even take them to theaters. And some of them might be suitable for what is presented today. So it's another option to consider as a damage control procedure in some selected group of patients to have in your armamentarium, because the second stage of surgery, instead of exchanging an X-fix to a rim procedure, an IM nailing procedure, might not be needed if you consider this approach. This is what I have to say, that is not for every patient, but is something that one has to keep in mind as another option for damage control orthopedics.
Thank you, Peter, for that. That's
Sultan.
absolutely the case. Yep.
Dr. Sultan, can I make a comment?
Yes, I was going to ask you, Dr. Narayan, please. Thank you. That's nice.
First of all, congratulations on a wonderful thing. I would like to say that this procedure definitely is anesthetist friendly, because it allows your patient to be on an ordinary table, no shifting here and there onto a fracture table and all the other things. The second thing is, most of these procedures are done out of hours by your senior residents. I don't think you as the chief surgeon would have been involved in a lot of the procedures. And currently, a lot of the residents and the youngsters are more comfortable doing a nail versus an external fixator. I don't know how many of them have applied an external fixator to the thigh without having to use much of C-arm intervention. And definitely, rather than struggling with an X-fix, a faster procedure to put in a lesser diameter femoral nail and locking it secondarily is a good option looking forward. I think looking forward with the number of IMNs that people are doing around the world, this is definitely a good option.
Thank you. That's true, but in our institution, no resident is allowed to go to do surgery on their own without supervision. So while it's not me, but there are colleagues who are more experienced in these procedures than me who do them. And that's why we have that excellent time and less damage.
Can I ask?
Yeah. Go ahead.
So
Dr.
in
Zaid.
bilateral femurs, how do you take a guess on the length of the nails?
We guesstimate. When the patient is on table, we take a measurement, rough measurement. So it's not exact science, but we just rough measurement. And the unilateral, it's easy. But that's a very good point. Thank you. There is a question from Dr. Pradit Patel. Go ahead.
Yes, sir. How many percentage of the patient will require a revision surgery or a definitive surgery?
Well, in this group, we've lost 3 patients to follow up. So out of the other 8 patients that are left, we had 1 exchange nailing for non-union. 1 patient needed lengthening of short femur. So the long-term results are quite good in these patients. But we cannot give the answer for the 3 patients that were lost to follow-up.
Thank you.
Great. So, Mohit, thank you very much. I think you can take it over from there.
Great. We've kept these short, and I wanted to thank you all for taking time today to join us. Of course, to you, Professor Al-Naskari, and obviously all the panelists. If you have questions, please do connect with Dr. Al-Naskari at your convenience, and join us for the remaining 14 or other small group lectures like this going forward. So thank you all, and have a wonderful rest of your day.